All right, well, welcome to this topic review in physiology on the basics of platelet activation and aggregation as a key component in the formation of a clot or thrombus. In the next few minutes, we're going to focus on core concepts that every healthcare professional needs to know and connect them to why they matter clinically. Because when you understand that normal physiology, then understanding the patho makes more sense, and which then improves the clarity in how we manage patient care situations and why we implement the treatments in the way that we do. Hey guys, I'm Dr. Busti. Thank you so much for joining me on This Is Why, a show dedicated to helping healthcare professionals understand the why behind the decisions that we all make every day in clinical practice. By the end of this review, you should be able to describe those key differences between a venous and arterial thrombus. You should be able to predict what happens when those processes of thrombus formation are unbalanced or exposed to pathology that makes things go wrong. And lastly, explain how platelet aggregation in the wrong clinical scenario can cause the intervention of certain types of things that we do to require proper regulation of it and to avoid those patient outcomes. So I'm going to give you some clinical pearls and even how you even monitor for platelets, and also how do you replace them if you need to, okay? So let's begin with one concept that makes everything else relevant: the platelet, their role and where they come from, okay? So platelets are essential to both arterial and venous thrombosis. We're going to see that here in just a minute. But the cellular structure they come from, it comes out of the bone marrow. Cells get released, they differentiate into different pathways. Okay? One of them that makes the platelets is the megakaryocytes. And once the megakaryocytes basically come apart and the platelets are released, the lifespan of those platelets are about 7 to 8 days to up to 10 days. That's the lifespan. So you constantly have this turnover that's needed. Now, when you look at the normal range and abnormal range, I put together a table for you that's available at thisiswhy.health for free. The link is provided to you down in the description, so that if you need it, or want to use it for studying, share it with friends, colleagues, or use it for teaching, you're welcome to do that. Okay? Those of you joining us on our podcast channels, I'm going to try to do my best to break it down. But what we have are the platelet levels on the left and kind of what is the interpretation on the right, okay? Now, the normal platelet count is somewhere around that window of 150,000 to 400,000, okay? You might see variations in that on your lab or assay. That's fine. Just recognize that that is kind of the normal. When you go over 400,000, that's thrombocytosis. You have more platelets available than you need. That doesn't necessarily mean that's good. More isn't always better, right? This can also be an identifier for underlying cancer. It can also increase the viscosity of the blood, making it harder for your heart to move things around, and just thicker. That increases the risk for certain types of clots. Thrombocytopenia. This is when the platelet counts start to go low, especially less than 100,000. And that's when, when we start seeing, obviously, they get concerned about the increased risk of bleeding and the type of bleeding. So when it drops below 100,000, there's a wide variety of causes that could be associated with that. ITP, TTP, HUS, heparin-induced thrombocytopenia, DIC, disseminated intravascular coagulation. All of those things can be reasons that they start to drop below 100,000 that you should stop and ask about. Now, once it gets less than 50,000, that's when that risk for spontaneous bleeding, not hemorrhage, more so, but bleeding in general starts to go up, okay? I didn't say everybody's going to instantaneously start bleeding, but the risk for spontaneous bleeding starts to rise. When you fall below 10,000, the risk for spontaneous hemorrhage really starts to raise. And that's why you need to know when to give somebody platelets and how to do that, which I will walk you through very briefly at the end, because it is very confusing when you don't think about the name and the way it's ordered. All right, now what would be the reasons for some of those low counts, right, in general? Right? So we talked about some of the conditions, but when you're having destruction or consumption that is exceeding production, that would be a reason. So you're using them. The platelets are being used, or you're destroying them. Autoimmune attacks or autoimmune activation like in heparin-induced thrombocytopenia, where we're turning on the platelets and they're aggregating and forming thrombus all throughout the body, which then infarct multiple organs, okay? Diminished production, okay? We know the lifespan is about that 10 days, but why would they not be surviving or being made enough? Thrombopoietin is almost like the equivalent of the erythropoietin that comes out of the bone marrow, for the kidneys, and stimulates the bone marrow to make more of those components of red blood cells. Well, thrombopoietin is necessary for the maturation and development of the megakaryocyte, okay, that leads to those platelets. And that's why patients with liver disease and kidney disease can still have increased risk for bleeding disorders because they lack some of that product to facilitate their production. And then those that are diluted from mass transfusion protocols, and then those that are maldistributed because you have redistribution of blood flow in the wrong places. We see this in cirrhosis where we have hepatic and splenic sequestration of various things. Okay, so now that you know the basics of platelets, let's move on to the thrombus formation so that we can see that application, okay? Now, this diagram or image is trying to just highlight the clot initiation to forming the clot plug and then the clot breakdown. So we're constantly doing that. And that's fine. We need that because you don't want to spontaneously clot. You don't want to spontaneously hemorrhage. You want some repair. And we bump into things, cut ourselves, all those things. But when you look at the underlying endothelial lining, which is this kind of this layer right here, where these cells are lining the blood vessel wall, if that endothelial lining disrupts itself from trauma, injury, or let's say it's an atherosclerotic plaque that's ruptured, the exposure of contents underneath, including collagen and other pro-inflammatory things, will turn on the local environment, the things passing through, platelets, right? Clotting factors, Van Willebrand's factor, all these things are going to be turned on and they start to create a repair. And that's what this is right here, okay? And this is your plug, where you have a clot or thrombus formation in that area, kind of like a scab. Now, the components of those differ depending on the blood vessel that you're in. Is it an artery or is it a vein? Okay, there seems to be a tipping scale of like which component, fibrin versus red blood cells versus platelets. Now, when you'll see here that a lot of times when this collagen gets exposed, and that's not highlighted on this image, but there's things floating around the blood called von Willebrand's factor that lays out in the collagen. The collagen can turn on and activate a platelet itself. We'll see that in a minute. You can see von Willebrand's factor will activate a platelet through glycoprotein receptors. Same thing with collagen. There's all these things being released. And when you activate a platelet, the platelet then releases chemicals in the environment around itself that can turn on clotting factors to propagate the coagulation cascade, that can recruit other platelets to the area and activate them as well, so that we get this thing repaired. Now, when that continues to grow, get bigger, and the vessel lumen is now compromised, well, now we have decreased flow. And in an artery, that can infarct an organ, right? Acute ischemic stroke, acute myocardial infarction. But also, if you're you can also have it in a vein where it decreases blood return. You have edema, you have thrombophlebitis, you have damage of heart valves in that area because it's cluttered all up around it. Depends on where we're at, okay? And that leads us to what is called a white thrombus versus red thrombus. Is something that you hear thrown around. But it really has to do more with the composition of the thrombus. So what I put together for you as a table where the two columns, you see their arterial thrombosis formation and venous thrombosis, okay? And then each row represents a characteristic. So what is the initiating factor for an arterial thrombus? Well, you see that vascular injury is true for both venous and arterial. But with an arterial, most commonly we're thinking of a ruptured plaque. The endothelial cap around that plaque ruptures, and that's what triggers like a myocardial infarction, right? You have plaques in the carotid arteries that can rupture and form clots. They break off, they go to the brain, acute ischemic stroke, okay? Now on the venous side, you see that it's altered blood flow, stagnation of the blood, where those clotting factors have now time to interact with each other and start to coagulate. We think of DVTs, deep vein thrombosis. Why do those occur? Because people don't want to move their legs after surgery, trauma, multi-abdominal pelvic trauma. They don't want to move. After surgery, they don't want to move. And so their risk of developing DVTs is high, okay? Now, what are they made up of? That's the next row. What is the composition? So that arterial thrombus is called a white thrombus because it's got less red blood cells in it. It's got fibrin and primarily platelets, okay? Whereas the venous thrombus has predominantly red blood cells and fibrin. That doesn't mean there's not platelets there, it's just not the predominant. So that matters because depending on the location of the thrombus, and in this case we're talking about platelets, where we're arterial, that drives the primary interventions that we want to utilize. It makes sense of the why. Why do we use antiplatelet drug therapy in patients with acute ischemic stroke or acute myocardial infarction, and we don't use predominantly, I'm not saying we never, we don't predominantly use anticoagulants? Because we're trying to interrupt the primary problem at the site of the pathology that we don't want to happen. So understanding the composition of the thrombus, where it's formed, why it was formed, what it's made up of, drives and explains not only that it helps understanding the pathophysiology, but it explains why the interventions are what they are. Now, at the end of the day, the result is still total or partial occlusion of that vessel. And so the manifestation of that occlusion could be ischemia in arterial side because there's no blood flow going to the organ that it was, organized around, right? So in the heart, it's the distal downflow stream of the coronary artery is going to be compromised, and that myocardium is going to be affected. In the brain, wherever that vessel was going, it's going to infarct that tissue. Okay, so that's why it matters. Now I do have a visual here, kind of just showing you the white thrombus concept versus the red thrombus concept, mainly just to drive home that composition. But you can see that fibrin monomers from the coagulation cascade are important. So if you do not understand the coagulation cascade or you've not fully reviewed it, I do provide a lecture on that in our anatomy physiology category. That's available at This Is Why, but it's also on YouTube for you. Okay, so I highly recommend that you learn it because you should not understand one only over the other. They work together. And hopefully I'm driving that point home. All right, now let's shift our attention towards the things that activate the platelet. I've kind of alluded to this already, but I really want to give it a little bit of attention because that's what drives the aggregation, the actual clumping, okay? So I have another image here for you. Again, trying to simplify things. It's not the end-all be-all. Doesn't represent everything related to platelet interactions, things. So you don't need all that. I'm trying to help you understand the main targets because a lot of these are intervention areas that we intervene on. So for example, ADP binds to our P2Y12 receptor. We have drugs that inhibit that. Things like clopidogrel, prasugrel, ticagrelor, okay? Collagen exposure, I talked about that. Remember, von Willebrand's factor floats by, binds to the collagen, it binds to the glycoprotein 1b receptors on the platelets, it activates them. Collagen interacts with glycoprotein receptors, activates the platelet pretty strongly. So when you see the arrow thickness here, the thickness of the arrow is trying to mimic or give you an indication of the degree of influence it can have on the activation of the platelet. Because the end result is the upregulation of these glycoprotein 2b, 3a receptors on the surface of the platelet. That's necessary for aggregation. So all those things on top are activating the platelet. The glycoprotein 2b, 3a receptors are facilitating the aggregation of those. And so our interventions, like we have drugs that block the glycoprotein 2b, 3a receptors right here, they're inhibitors, and so they're primarily affecting platelet aggregation. Whereas drugs like aspirin that blocks thromboxane A2, that's an antiplatelet drug. Well, you're not shutting down all platelet aggregation by giving somebody aspirin. You have all these other components that can turn on and activate the platelet. And that's why sometimes we'll use dual antiplatelet therapy in certain conditions where someone's on aspirin, but they're also on a drug like clopidogrel. Right? We see that a lot in patients with drug-eluting stents in coronary arteries. They need to be on both of them to protect that stent from reocclusion by platelets. We're in the artery. Okay? So I hope that understanding that normal physiology helps to explain some of the pathophysiology, which then leads to the understanding of the drug interventions that we are using. But you have to look at this in the context of the entire system that's going on. Now, on this diagram, this is about looking at clot or thrombus formation, which is down here at the bottom. You see two arrows feeding into it. You have fibrin coming from the coagulation cascade on the left, but you also have platelets feeding in. And again, the composition or the amount of influence that each system has is due to the location, in part. So you see that vascular injury can trigger it, turns on the coagulation cascade, tissue factor gets released, we then propagate the coagulation cascade, and then both intrinsic and extrinsic pathways converge at factor 10. And then when 10 gets activated, it converts prothrombin to the very important target thrombin, because thrombin plays a lot of roles. You saw that on the previous image, that thrombin was one of the activators of a platelet. Well, it does. It activates platelets through PAR1 and PAR4 receptors. Okay? And so that becomes very relevant. But thrombin also plays a very important role in regulating the activation of the coagulation cascade. Again, I cover that in the coagulation cascade lecture, so make sure you know that, because this is a huge target for drug therapy. So is factor 10. And there's reasons for that. It makes sense. Trying to regulate that fibrin production in the clot and also regulate the activation of platelets. Now, does the body have anything to turn off platelets from aggregating? Yes, it does, right? So I've tried to highlight those here, these endogenous components for you. The first is nitric oxide. Okay? Nitric oxide is normally made by the endothelial cells in the blood vessel, assuming that the endothelial cells are normal and functioning right. If they have a bunch of plaque in that environment, they lose that ability. And that's one of the reasons why coronary artery disease patients will have vasospastic angina, because they lose some of the endogenous protection against like local vasodilation, but also antiplatelet effects. Prostaglandin I2, PGI2, okay, is a known prostaglandin, again, also made locally, that has antiplatelet properties and vasodilatory properties. Now, so drugs like COX inhibitors, NSAIDs can block those prostaglandins. That takes away the vasodilation, it takes away the antiplatelet effects, and that's why those drugs have not been helpful in protecting patients against cardiovascular disease. And we avoid them traditionally in patients with cardiovascular disease, okay? Now, are there any tests that we can do to help us understand platelets and their function? Are they being activated and are they aggregating? And of course, the answer is yes. We have a number of them. One of the oldest is the bleeding time. Like literally, you're cutting the patient and you watch them bleed and you time it. How long does it take them to stop bleeding? All right, that's obviously not as ideal. It seems kind of cruel. Family members are watching you, cut on the patient and sitting there watching them bleed, looking at your watch like you're bored or something. That's not ideal. So it's kind of fallen out of favor, although you can technically do it, right? There are point of care tests that have evolved that allow us to do that. There's light transmission aggregometry, there's flow cytometry, there's platelet functional assays and analysis that can be done, right? So it just depends on your institution's lab capabilities and assays. It also is influenced by your practice, what's feasible. But those are some tests that we can utilize to guide us, okay? All right, next is, platelet administration. I mentioned that earlier. What do you do when your platelets drop too much and you're using them and you got active bleeding going on? Remember, usually when that's less than 50,000, the risk of bleeding goes up. The risk of spontaneous hemorrhage really starts to go when you get less than 10,000. And so administering these can be important, and right, we have to also be considerate of the drugs that have antiplatelet effects, that especially those that are irreversible, like aspirin is a cyclooxygenase inhibitor, COX-1 specifically in the platelet, it's irreversible. Clopidogrel, prasugrel, irreversible inhibitors of P2Y12 receptors on the platelet. Okay? Those things can all increase the risk of platelets not being functional and also the risk of bleeding. So if we have to give somebody bleeding platelets back, you got to give them as units. And I'm telling you, it's confusing. And if you don't do it enough, this is more on the inpatient side, obviously. But there's 2 units. What I mean by that is the spelling of it. There's a capital U, and then there's a lowercase u. So a unit of platelets represents 4 to 6 individual unit packs. Okay, I know. So what it looks like is basically this, right? So I've underlined and showed you in this image there are 4 bags or units, small units of platelets that make up 1 capital unit of platelets. So when you order them, you have to pick the right unit spelling. Very confusing, isn't it? But that's relevant, and I wanted you to be at least vaguely familiar with that. But if you also look at the color, interestingly, it's not red, right? So that's that red versus that white sort of thrombus. Okay, now I'm a firm believer that, again, when you learn content like this, okay, you need to know what builds on it. This is the foundation for understanding that pathophysiology. I can't stress that enough, but also treatment options that we have to modulate these activities in the pathways. Okay? So one of the things I wanted to provide you next is just a very basic table of some of the platelet problems that can occur. I'm not going to walk through each individual disease state here. Those are for separate discussions. But I wanted you to see where this stuff going. So right at the beginning I talked about reasons why the platelets drop. Thrombocytopenia. And there's a number of them. And this table that I'm providing you here, again, is available at thisiswhy.health. Tries to break down each type, ITP versus TTP versus HUS, DIC, and then, of course, HIT. What are some of the factors or variables that you need to consider? Are there schistocytes, basically breakdown products from cells from being hemolyzed, like you see with TTP, HUS, right, and DIC. Haptoglobin, which is binding things from those cells that are being broken down. Are they being impacted? So if haptoglobin levels are dropping, that means that red blood cells are probably being broken down somewhere, right? These are individual disease states, but I wanted you to see why they exist and some of the underlying etiologies that would cause a thrombocytopenia. Now, there's also platelet function disorders, right? We talked about glycoprotein 1b receptors. Remember, that's where that von Willebrand is going to help bind that when it exposes, when the collagen is exposed from the damage of the underlying vessel, right? Bernard-Sauer disease. Those patients have a defect in the ability to bind that collagen in the van Willebrand factor, and so they're more likely going to see an increase in the bleeding time. They can't form clots in that arterial environment. Glandsman's thrombocytopenia, they lack and have problems and defect of the glycoprotein 2b3a receptor. Remember, that's that final one that with all the activators of the platelet get compromised. That's a big deal. And then lastly, there's something called uremic platelet dysfunction that we see really in patients with CKD on hemodialysis. They have platelets. The numbers actually look normal, but they're not functional platelets. There are other things that get created when you're not eliminating things from the body that make that platelet from not working. We also have endogenous problems with nitric oxide and prostacyclin that contributes to that. So it's a very complicated disease, but patients with CKD will spontaneously start bleeding even with normal platelet counts. All right, guys, let's now take a moment and let's pull this back together from where we originally started. That goes back to the clot. What type of thrombus is formed and why, and is influenced by where and the underlying pathology. So again, if it's in the arterial side, usually from plaque rupture, we're going to predominantly see platelets. Call that white thrombus because of the color. That doesn't mean there's not red blood cells or fibrin, it's just predominantly made up of platelets. So we're going to use a lot of antiplatelet drug therapy in those conditions. That hopefully makes sense to you. You don't need to memorize that. It should be a foundation for thought and expansion of the understanding of drug classes and disease states. For on the coagulation cascade side, right, venous thrombosis, where we use anticoagulants, and we have conditions like hemophilia, right, von Willebrand factor problems, right? Those kinds of conditions become very relevant for us in considering what treatments. That makes sense of why we have the distribution of drugs and we pick one over the other. Okay, I can't tell you how many people get that sort of mixed up because you're looking at a system of hemostasis that involves multiple pathways. That's why you should not learn them in isolation, but you should consider the totality of them and how they interact and influence each other. All right, guys. Well, I certainly hope that you found that to be helpful. If you've already learned some of this stuff in the past, it was a good review. I would really appreciate that if you've not done so, subscribe to us on our channel so you can kind of keep up when we publish new content. Our goal is to feed into all of us in our understanding about why we do what we do, okay? Also, we offer free memberships over at thisiswhy.health where you get some extra things, tools, download top images and things that you can share. We'll be doing live events, things like that in the future. You can also ask questions for future topics, things like that. That's there for you, right? The goal is to create a community where we're learning from each other, helping each other, because that's where we're going to succeed most in caring for the patients that are dependent on us. So thank you so much for your time. We'll see you on the next episode.